reconstruction. So the tumor entry routes. So grossly, the tumor enters the mandible through a point of abutment, to the point of abutment, which can be occlusal surface, which can be the periosteum, or when there is a large tumors, when there are large paramandibular tumors, there can be multiple routes of entry. So in this image, we can see that the tumor enters through a point of contact. It enters through the point of contacts in the dentate mandible, through the dental socket, and then goes to the cancellous bone, and then involves the alveolar canal. With respect to the when there is an edentulous mandible, so after the teeth is lost, the alveolar portion of the mandible starts resorbing, and the remaining the remaining mandible is called as the alveolar ridge. So in this alveolar ridge, tumor invasion again occurs through a point of contact, through the dental pores onto the alveolar process, to the cancellous bone, and then to the alveolar canal. So basically, there are two pattern of invasion. First one is invasive, and second one is erasive. So in invasive, there are finger or islands of tumor advancing deeply into the bone with no obvious osteoclastic activity. Whereas in the erosive front, there is a broad advancing front with osteoclastic activity, and there is connective tissue between the tumor and bone. The invasive includes that they are large, deeply invading tumors are more likely to demonstrate an invasive pattern of spread and involve the mandible. However, in erosive pattern, as the depth of invasion increases, they become more invasive in character. So invasive patterns are more likely to give rise to cervical metastasis with extracapsular extension, and are more aggressive in nature. So, few things can be taken into the consideration, that the mandibular should be considered at risk at any point when the tumor is in contact, and this is taken into account when planning resection. Clinical fixation of the tumor to the bone is not necessary for bone invasion to occur. Primarily, the size and extent of the tumor dictates the pattern of spread once in bone rather than the anatomical features. And preferential spread within the mandible via inferior alveolar canal at the medullary space is rare, and this justifies our 1 centimeter margin. So this study, Invasion of Mandible in GBS Complex Cancers by Devendra Chokar et al., was published in the Journal of Oral Oncology. So the purpose was to determine the most accurate imaging modality predicting mandibular invasion in GB complex cancer, and pattern of invasion and routes of entry into the mandible by detailed histopathological analysis. This was a prospective observational study including 70 patients, tumor juxtaposed with the mandible, clinically necessitating seeing some form of mandibular resection. So there were two conclusions. One was with in relation to the most accurate imaging modality, and one was with the route of tumor entry. So they classified tumor entry into three. One was the occlusal surface, that is infiltration of the tumors cells into the mandible through the occlusal surface, either through the periodontal ligament or adjacent periosteum, were labeled as such. Then again, the second was the point of abutment, where infiltration of tumor cells into the mandible through a point of abutment. In retromolar trigon, the occlusal surface corresponds to the point of abutment. Bone invasion in such tumors were labeled as occlusal route of entry. Multiple routes, as mentioned earlier, when there is a large paramandibular disease, so when tumor cells infiltrate the mandible through all of the above routes, it was termed as multiple routes of entry. Now, assessing the bony erosions. So the goal for preoperative imaging is to determine the presence or absence of mandibular erosion. Bone destruction, if present, confirms the tumor invasion, and to plan for the appropriate type of resection. So the anterior posterior extent of erosion can be seen on the axial sections. Height of the uninvolved segment of mandible from the inferior border can be seen on the coronal imaging to plan for the marginal or segmental mandibulectomy. For bony invasion, mandible height, dental anatomy, pathology are seen. Plain radiographs do not detect initial invasion until 30% demineralization has occurred. So this has reduced sensitivity. Absence of radiographic findings does not rule out bony invasion, and radionuclide bone scan often are positive before radiographic appearance of the bone destructions. So this table is from the Stellen Maran's textbook, which shows that the highest sensitivity was for the single photon emission computed tomography SPECT, and the highest specificity was for the computed tomography CT scan. Again, this is the continuation of the previous study. So uh, invasion, this is the continuation of the previous study. So they also have assessed various scanning modality, which included OPG, MD, multi-detector CT scan, dental scan, and SPECT scan. Sensitivity was 100%. Again, it is in relation correlation with the previous table, was 100% for the SPECT scan, and specificity was highest for the OPG. So in this study, they concluded that GB complex cancers are homogeneous group of cancer with respect to mandibular invasion with preferential route of tumor entry through occlusal surface. Multi-detector CT scan is fairly accurate in preoperative assessment for invasion as well as estimation of involvement, as substantiated by the histopathologic analysis. Large tumors with paramandibular disease are likely to have multiple tumor entry routes, contraindicating mandibular conservation, and oncological safety can be achieved by positioning the bone cut margin corresponding to the adjacent soft tissue cut margins in segmental mandibulectomies. So these two are the axial section of the CECT. So the here we can see a tumor which is present abutting to the mandible. So when we get into the puff cheek, we can see that the puff cheek separates the buccal and gingival surface with air dissipating. That the epicenter of the lesion is in the buccal mucosa. The lesion does not appear to the mandible as seen in the previous this image. Here we can see that the tumor is abutting the mandible, but when we did the puff check, it was seen that the epicenter of this is in the buccal mucosa and mandible is free. Again, this is the first picture is of the oblique MDCT deformation showing extensive mandibular, this arrow, extensive mandibular erosion reaching inferior alveolar canal. And in the this is the coronal section of the CECT, which shows large paramandibular soft tissue mass abutting the last surface of mandible, this without erosion. In this image, there is a lower GBS. Again, it is the coronal section, lower GBS mass abutting mandible. And in the coronal reformat, it shows that there is a subtle erosion of the buccal cortex, this long arrow. Short arrow on the opposite side shows the intact cortex. And this line shows the height of the uninvolved mandible, which in this case is approximately 2 centimeters. So coming to the mandibular resection part, which can be broadly divided into rim or marginal mandibulectomy, which can be defined as the removal of a portion of a bone with maintaining the continuity of the mandible along the lower border. Segmental mandibulectomy can be defined as the removal of the portion of the bone without maintaining the continuity. And periosteal resection is removal of the mucoperiosteum of the bone. So indications for the marginal mandibulectomy are no bony erosion or superficial erosion, tumor close to the mandible to achieve the adequate margins, minimal periosteal involvement, and T1, T2 tumors with adequate bony height. Contraindications include gross bony erosion, post-RT edentulous mandible, gross periosteal involvement, or paramandibular disease. So this study by the Murakami et al., which published in the Journal of Oral Maxillofacial Surgery, which biomechanical analysis of the strength of mandible after marginal resection. So they investigated the biomechanical behavior of the mandible after marginal resection by tensile test in human cadavers. Models after marginal resections were prepared with residual heights of 5, 10, and 50 millimeter, and strength was examined by the tensile testing. So they concluded that a residual height of more than 10 mm more than or equal to 10 mm, and reduction of bite force are recommended to reduce the risk of fractures. So, Sudhir Nair et al., they gave the classification of the marginal mandibulectomy in oral cavity cancers. The first type is horizontal marginal mandibulectomy, where a mandibular rim is resected horizontally. Coronoid process may or may not be removed, performed for small primary lesions, which are further subdivided into three groups. Okay. I think that slide is missing from this. So coming to type 2, oblique, no, it's not missing. So this one is A, where there is anterior. This one is A, where there is anteriorly the central arch segment, a portion of the alveolar portion is removed. In B, there is posterior, the lateral segment, posterior dental alveolar part is removed, which is not involving the coronoid process. And in the type C, there is involvement of the coronoid process. Coming to type 2, oblique marginal mandibulectomy, performed for tongue or floor of mouth lesions close to the mandible. This lesion is also away from the mylohyoid. So this is the oblique marginal mandibulectomy, which is involving the buccal and the lingual cortical plates. So vertical marginal mandibulectomy is done on the lingual side. It involves a vertical resection of the lingual plate of the mandible, focusing on the internal aspect of the mandible. And fourth is reverse marginal mandibulectomy, when there is cervical lymph nodes adherent to the mandible without cortical erosion. So, what is something called as pipe stem edentulous mandible? So, what happens when there is this alveolar part of the mandible? So, when there is a tooth is lost, it goes into gradual resorption, and once they start resorbing, so in the edentulous mandible, the inferior alveolar canal, it comes to the superior portion. So, in most of the times. Normally when you see in the dentate patient, you can see that the normal position of the mental foramen, this can be a clinical, like we can understand it clinically. The normal position of the mandible foramen, mental foramen, is somewhere between the first and second premolar towards the apical third of their root. So when we have, when there is a loss of teeth and when there is resorption, so this mental foramen comes to the occlusal surface of the remaining alveolar ridge. So there is hardly or barely any distance between the alveolar canal and the superior occlusal alveolar ridge. So this is called as this pipe stem edentulous mandible. While doing marginal mandibulectomy, there should be, we should avoid right angle cuts, as there will be excessive stress which can result into spontaneous fractures. So, however, our cuts should be, osteotomy cuts should be smooth, cano shape to evenly distribute the stress. Coming to segmental mandibulectomy, indications include gross bony invasion, invasion of inferior alveolar nerve or medullary canal, significant paramandibular spread, primary mandibular tumors, and wherever marginal mandibulectomy is not feasible. So, grossly, it can be divided as.
Vijay,
Yes,
Vijay,
sir. Yes, sir.
that you have left one more indication for segmental mandibulectomy. Do we do marginal after radiotherapy? Suppose a patient has got radiotherapy, will you do marginal or
Yes,
segmental?
sir. Yes, but I had mentioned that in the contraindications of the marginal mandibulectomy. So patients underwent after radiotherapy or edentulous mandible is also indication for segmental mandibulectomy.
Okay.
Thank you, sir.
Okay, go on.
So primarily, this can be mid third segmental mandibulectomy, which is between the two canines, removing the arch of the mandible. Then there is lateral segment, which is beyond the mental foramen, and then there is hemimandibulectomy, which is from the symphysis to the condyle sparing or condyle including, and the posterior segmental, which is posterior segment, which may or may not include the ramus of the mandible. So Ukraine et al. In 1991, based on the mandible and soft tissue defect, they classified mandibular defect as H, denoting capital letter H, which means that lateral defects of any length, including the condyle. L, lateral defects of any length but not including the condyle. And C, entire central arch from canine to canine. And the soft tissue defects were classified as none, involving skin, involving mucosa, and through defects. Beyond et al. Classification, there were 3 uppercase and 3 lowercase letters. For bony defect, it was similar to the previous classification which I've seen, and a combination of for soft tissue defect, it was denoting with O, neither skin nor mucosa. S equivalent to skin, involving skin, and M is involving mucosa. And through defect was denoted with the letter S and M. A combination of letter is possible. For example, a defect from angle to angle can be mentioned as LCL, lateral, central, lateral. A new classification for mandibular defects after oncologic resection was given by James Brown et al. In 2006. So they classified into 4 classes. First one was class 1, which included the lateral defect, not including ipsilateral, canine or condyle. So this letter C is mean that the in every class means that it was including condyle. So class 1 is lateral defect not including ipsilateral, canine or condyle, whereas 1C was lateral defect including condyle. Class 2 was hemimandibulectomy including ipsilateral but not contralateral, canine or condyle. Class 2C was including condyle. Class 3 was anterior segmental and anterior mandibulectomy including both canines but neither angle. Class 4 was extensive anterior mandibulectomy including both canines or one or both angles. Class 4C was it was involving one or both condyles. Coming to approaches, so how the approaches to this segmental or marginal mandibulectomy. So when there are early superficial lesions or very anterior lesions, adequate mouth opening, surgical field is accessible, per oral approach can be utilized. So you can see in this image, this is a buccal mucosa lesion and in the buccal mucosa towards the anterior side. So this resection is done using per oral approach. Cheek flap, the lower cheek flap can be used for large cancers posteriorly placed, deep infiltrative bony lesion, or when the bony resection is required. So the tumors which are posteriorly placed, even if the tumor is small, we should go on for like a low cheek flap approach or extraoral incision approach, because we should not try to do it per oral approach, because the third dimension, the base, is the margin which most of the times is difficult to be removed and it can come close. So this per oral approach for the lateral segment of the marginal mandibulectomy, then midline split incision approach for the tumors located away from the commissure. So this again lower cheek flap approach for segmental mandibulectomy. Visor approach, the benefit is the mandible can be completely exposed from one side of the ramus to the other side of the ramus. We can use when there is anterior segmental mandibulectomy, large resections crossing the midline from one side of the body to the other side of the body or angle. Yeah, again, this diagram, a lower lip split techniques. The conventional one is a straight midline. Then there is a midline with jet plasty at the labiomental crease. Angle split or commissure split incision. This is done when the tumor approaches or it is nearby to the commissure. Approaching the commissure or nearby to the commissure. Then chin preserving. In this diagram D figure, it is preserving the chin contour, and the last one is with Z plasty at the vermilion and chin preserving at the submental region. So this figure, we can see that the lip vasculature from the superior and inferior labial arteries on the other side, a midline split in tumors. When there is a midline split in tumors reaching to the commissure, results in devascularization. Like this is the tumor, and if we take a midline incision, then this part will be will result in devascularization. So this now coming to the problems or complications with the mandibular resection, which is this is results in the malocclusion. This results in difficulty in speech, swallowing, mastication, oral competence, tongue fall and mobility, restricted mobility, and what we say appearance. Again, cosmetic problems.
So
So
Vijay,
this
like you are discussing about the various approaches. One, like you discussed about the midline approach. And what is the name of that approach?
lower midline split.
That is your with lip split and chin split. No.
Yes, sir.
So what is the disadvantage of this incision?
Sir, the commissure, the lip commissure is split approach is taken when the tumor is near the commissure, and the lower lip split
No,
incision midline is taken when it is away from the commissure.
that's what I know. But what is the disadvantage of taking the midline split approach? And what is the disadvantage of taking the your angle split?
Sir, in midline split approach, sir, with respect to the tumors near the commissure, or
Yeah, yeah. I
so,
think you're
sir,
not getting the point. Yeah, yeah. I am
sir,
asking you.
yes, sir,
Yeah, I'm asking you, like once you are splitting the lip as well as the chin, like a straight line we make, no normal,
yes, sir.
like as often is central arch, if the disease is anteriorly and all many a times. So what is the disadvantage of taking that incision?
The scar, soft tissue contracture and scar, well, this,
Yes,
and
right.
again there will be sagging of the chin in the vertical
Yes.
split.
That's one thing is that you are cutting the your orbicularis or
Or
oris muscle, okay,
mentalis
and one
muscle.
is that it will lead to your anxiety scar. So to like prevent that scar, we make a zigzag or jet plastic kind of thing we
Jet
do.
plastic. Yes, sir.
To correct that. And what is the disadvantage of taking your angle split? And the name of incision is your Robson incision. We call
Option.
it. So the main disadvantage is that at that point you are cutting the blood vessels as well as the branches of facial nerve.
Facial nerve, marginal
Yeah.
mandibular. Yes.
So your neurovascular compromise is more in that case. But advantage is that your there is less scarring and because it hides in your natural lines of Langerhans, no, and the skin which lies. So there is a very good article about the various kind of incisions on
Yes, sir.
the and so like you should go and read about this and next time just tell us in detail. There are various other modifications about all those approaches. Okay, go on.
Uh, Coming to the mandibular reconstructive ladder, this is taken from the Stellenmaran's textbook. So no bony reconstruction, then which includes the direct soft tissue closure in insertion of local flaps, soft tissue interposition, and alloplastic materials. Then bony reconstructions include non-vascularized bone with or without soft tissue flap, which includes free bone graft, costochondral grafts, then vascularized bone including pedicle flap or free flap. Then other technical method modalities include destruction osteogenesis, TMG reconstruction, and dental implants. So, anatomic consideration for mandibular defect reconstruction is cosmetic deformity and functional loss that occur after resection depends on size and location of the segmental defect. So, anterior defect, that is greater deformity and greater loss of function. Posterior defect is better tolerated, but a malocclusion may result in a dentate patient. And lateral defect, deviation of mandible towards the resected side due to unopposed pull of remaining muscles of mastication. So no bony use then using alloplastic materials in reconstructing the mandible. Ideal ideal material is biocompatible and able to withstand the forces sustained by the mandible in mastication. Medical polymers, ceramics, and variety of metals were used. Titanium reconstruction plates and the THOR, which is titanium hollow osseointegrated reconstruction plates, are able to withstand the masticatory forces, and plate fracture is much rarer. But thing is, there is a complication of plate exposure following radiation or anything. Improving the soft tissue vascularity around the mandible with free tissue transfer or pedicle flap reduces these all complications of the so bone graft plus minus soft tissue coverage. It was introduced by Bidenhuber in 1881. Block grafts or particulate cancellous bone in metallic trays were used. Non-vascularized bone graft was used. Defects smaller than 5 centimeter in length in healthy surrounding soft tissue and not to be treated with post-operative radiotherapy. Autologous allogenic xenografts were used. Autologous had the osteogenic potential, while rest acts as a scaffold over which patient's cells can induce bone formation. The greatest site for harvesting the autologous bone in terms of quality and quantity is the anterior or posterior iliac crest. What are the advantages of this method? This modality is that it is quick and easy technique, no viable neck vessels required, no risk of microvascular failure. However, the disadvantages include a healthy bed of surrounding tissue is required, high risk of bone resorption along with infection, increased complications when there is radiotherapy, and inability to carry out composite reconstructions. Coming to microvascular free flaps, the ideal composite flap must have skin with that will resemble oral mucosa, good bone quality and quantity with blood supply that is reliable enough to allow osteotomies and subsequent dental rehabilitation. Minimal donor side morbidity. This four flap can be used for mandibular reconstruction, which includes free fibula flap, deep circumflex iliac artery flap, scapula flap, and composite radial flap. So we most commonly we use the free fibula flap for the reconstruction of mandible. The advantages includes that the length of the bone, like up to 26 centimeter of bone, is available for transfer, and it is the only single flap that can be used for total mandibular reconstruction. The bone quality is good, and we have a good pedicle length, consistent anatomy, good skin quality that is reliably transferred, and two operating teams are possible. However, disadvantages include high incidence of atherosclerosis in the lower limb vessels and lack of the height of bone. Like the vertical height of the mandible is more than this than our fibula flap, and this can be overcome by placing the uh, uh, fibula graft in parallel to line up in parallelly to the or in relation to the occlusal plane. So the lower border, lower border will be uh, like that will be deficient over the lower border of the mandible. The Nonsi et al. They did some vertical distraction. However, the results were not that good. So in this image, you can see total mandible is reconstructed with this fibula. It was the both this part were attached to the like ramus part attached to the condyle, and the anterior part the lateral segments. Distraction osteogenesis, growing new bone by distraction, that is stretching of pre-existing bone. The initial bone formed is non-lamellar and gradually replaced by lamellar bone. Distraction devices are intraoral, extraoral. So this study by the Moni Ibrahim et al., the reconstruction of segmental mandibular defects by distraction osteogenesis for mandibular reconstruction. They did it on 4 patients, but there were only 4 patients. In 2 patients, there were complete bone regeneration. But in 1 patient, there was recurrence, so it was a failed case. And in 1 patient, there was some partial regeneration of bone. So what they concluded is that the critical mandibular segmental defect of 3.5 to 6.5 centimeter was their inclusion criteria. Segmental bony defect flanked by adequate bone stock for the creation of transport discs and very limited soft tissue defects. Coming to dental implants, so these are the biocompatible titanium materials which can be used in the fibula bone graft or any of the bone grafts for placement for restoring the dental part. So uh, when we reconstruct with any of the flap, there is reduced alveolar bone height, there is poor lingual and labial sulcus, there is reduced tongue mobility, post-operative radiotherapy induced xerostomia. All these factors make conventional dentures very difficult to wear and construct. So then this can be bypassed with the use of dental implants. Coming to the temporomandibular joint reconstruction, mandibular condyle should be preserved if possible without compromising the tumor resection. If preserved, the new bone must be fixed to it. Condyle must be positioned in the clinoid fossa at its preoperative position. If condylar head needs to be sacrificed, bony flap can be directly placed into the clinoid fossa. Fibula is the ideal bony flap for TMJ reconstruction. And if the patient is dented, a prosthetic condylar head can be used with a bony flap that provides more predictable occlusion. So in costochondral graft were also used in the more commonly in the pediatric patient for this condyle reconstruction or TMJ reconstruction. But the main disadvantage is it can like the growth is continuous, so it can result into the it can overgrow and result into the asymmetry. Thank you.
So Vijay, like
Yes, sir.
didn't you talk about like various kind of plates just for our knowledge, because people are in a better position to comment on that, like where to use your weight bearing plates, where to use weight sharing plate, why we use titanium, what is CAD cam and all. I think those
Sir,
slides you.
cat. Yes, sir. Yes, sir. I have not included that because this is again a different topic. So, sir, the plates we used in our center are the mini plates, which are weight sharing, stress sharing one. The reconstruction plates are the weight bearing plates. So it is a mostly continuous 2.5 or 2.7 millimeter diameter. And yes, titanium plates are more biocompatible. They do not require to be removed. And the CAD/CAM is the computer-controlled manufacturing of the patient-specific implant and everything. We can give 3D implants specific to the patient.
Okay. So anyone want to ask anything?
Sir, recent dental extraction or poor dental hygiene, or we anticipate the patient might land up in dental extractions after surgery. Would that be an indication or a contraindication for any bony resection?
Your assessment and rehabilitation. If you feel that some tooth are to be extracted, those things should be or extracted before surgery or during surgery. Means because you need a good oral hygiene to take care of the adjuvant therapy and all. Because after that, you will not be able to do these procedures because of the increased chances of the ORN and all. So, means
Will
just
that
for
change my
doing this,
management for marginal to segment?
what?
If
Then
I,
get it. Yeah,
after,
yeah.
if a person has done recent dental extraction, in that person, shall we prefer segmental, or we can go with the marginal if we can get the margins?
No, I don't think so. Like because you have to see what are the indications of doing it marginal as well as mandibular. Like, basically, you have to preserve the height of mandible. It should be 1 centimeter so that it can bear the weight and your mandible doesn't crumble. So just your recent dental extraction, if you are getting a margin of your clear margin, it is away from bone. It is not a paramandibular disease, then it should not be an indication of segmental, what I think.
ORM chances will be high in that case, sir. No?
No, orange anyway, like you are cutting the bone, orange chances will be high once you do it after, your, like if your physiotherapy has started and all, um, then the chances will be high. Like you
Okay, sir.
want to ask like a patient is having a disease and he has undergone your tooth extraction, and then just like we should do a segmental so that because of that tooth extraction,
Yeah,
because you have a.
already it's infective field already because
No,
of
no, because
extraction
there is
and
a period. No, like we don't immediately do radiotherapy, there is a time interval. By the time that part will get healed, because generally after surgery it is started after around maybe after 6 weeks. So for that much period is okay for healing of that bone. If there is any obvious indication of doing segmental, then we have to do that. The only thing is that once your radiotherapy has started in the midway or just after radiotherapy, these things are not done.
Okay.
So it was a nice presentation by Dr. Vijay. So I think a few things you should have mentioned, like SCAD cam and all, but maybe in the next class or in the next topic, those things can be covered in. Uh, so,
Okay.
Vinay sir, any comment from your side?
Um, According to the scenarios, yeah, we could have discussed about how do we treat like what we consider in benign cases, malignant cases, and what would be the alternate options of sections or reconstruction. Yeah, we could have taken it a little further, but yeah, he has covered most of the topics.
Yes. So nice presentation, Vijay. So I think the next topic is who is going to present next?
So it's, Surbhi is going to present next.
What is the topic?
Melanoma. Melanoma.
Melanoma of head and neck or what?
Cutaneous
Head
melanoma
and
of
neck. Cutaneous melanoma of head and neck.
head and neck.
Okay. Okay. Okay, then thank